The Week in Review, a podcast for clinicians, by clinicians, all on the path to clinical mastery and having a hell of a time along the way. Before we get going, I need to check to see if we have no more reviews than we did last time. I hope we don't have any, actually.
I think we're going to have one. Well,
like one more or one?
Well, one would be one more.
I think Tyler Limburger.
Tyler the trainer. Yeah.
How many different variations of Rowan Gardner does he say on Rookie of the Year?
Yeah.
Rosenhauser. I can't even find our show. Does that exist? Yeah. To the bottom. Last one came in 2 years ago. So we appreciate the love. This will just keep the reviews up, and we really appreciate it, especially all our sponsors. They appreciate it too. Somebody's trying to come in. Ain't gonna happen. We were going to do this with our new Twitch account because we got the latest games on N64, but
someone let us down.
Yeah, kind of like his Achilles, the N64 didn't show up for competition day. So.
Sorry, it's older than I am.
I guess there's a massage patient out there. There's people lurking in our office.
Hands.
Yeah. 2 cases. Boom, boom. Any updates from any old cases? Everybody still alive that we treated?
The last girl, we talked about runners last time. Their team got second in
You
state.
have that mic there.
Their team got second in state.
I need those little mics you wear around
We
your
can
neck.
just clip it.
Yeah.
And she ran a PR. Was like 3rd for their team.
Cool.
So she's running the mile this weekend. What about yours?
I have no clue.
Okay.
Still alive.
Pretty sure my last case was
Do you guys know how she
3
did
months
it?
ago.
The state, she didn't do too bad.
Yeah, I think she was second for their team.
Yeah. Not a PR or anything.
Yeah. I think she was close.
I thought she was 1950.
Close
She's run
still isn't a
1945,
PR,
I think.
Alex.
Okay.
Lawn darts, hand grenades. What were you saying?
And Alex Coleman. I think my last case was 3 months ago, so I think he's doing good. I couldn't even tell you what case I did last.
I can.
Okay.
I feel like, is your chair really that tall? You're sitting very high compared to the rest of us. Is that on purpose?
He came in this week
So low.
to see Dan.
That's the one I'm doing today.
Oh, whatever.
Oh my gosh. Speaking of, let's let Seth kick things off.
Oh, I'm starting? I thought Alex was starting. All right.
Oh, who wants to go first? I think you guys should Rochambeau.
What is that?
Rock, paper, scissors.
That's what I thought.
Are we going on shoot?
On shoot.
Is it 2 out of 3?
It's 1.
Okay. All right.
Boom.
You go first, then you won.
Okay. Whatever.
You won.
We didn't specify that.
Seth's
You're right.
up.
Alex is up. He won.
Yeah, he gets choice.
Okay.
Dealer's choice.
I'll go first.
Heck yeah. Look at that.
Lady and gentleman, it's 2023. He can do both.
Okay.
Unlike these chords.
Okay. All right. So
Low T.
we have a 16-year-old high school soccer player, middle distance runner with left anterior knee pain that has gone on and off for different seasons of soccer and track for a couple seasons now. She just finished soccer, is about to start track, and came in with kind of like a flare-up, I guess, of the pain. Bothers her most when she's running, jumping, squatting, landing, kind of the usual. And it's really focal over the patellar tendon, kind of at the insertion of the inferior patella. No noticeable swelling, redness, any of that when I saw her that day.
Of her or the injury site?
Injury site. I wouldn't say she's a swollen individual. Yeah, no Benadryl needed.
Just checking.
It's a fair question. I like it.
Yeah.
The 3, what you're saying, you got a general wellness, and then that gets deleted after first visit. So
Yeah.
If our boy Tanner Zimmerman's listening, her family hails from the land of Pella, Iowa, where he went to school. So, and so it's kind of just gotten progressively worse, where it was not really bothering her outside of activity. Then it started to bother her after practice, and then it was like into the next day. So on her exam, she's top tier SFMA, dysfunctional non-painful, multi-segmental extension, left multi-segmental rotation, and then single leg stance bilaterally. Functional painful deep squat. Then, like I said, pain over the patellar tendon at the inferior pole, and then also pain with Thessaly's. That was the main kind of stuff with the exam. No limitation in range of motion in your knee. So I didn't really chase any sort of McKenzie in range loading because she had full range of motion. And then as far as functionally, kind of the main things that I pulled out of the exam were she had some trigger points in TL erectors bilaterally. And okay.
Yeah, okay.
Yes. And then as we were looking at breathing in part of my exam in supine position, she had a really hard time creating that TL punctum fixum, which is just kind of living in extension while she's laying on her back. Then later on in the exam, I was looking at kind of how she was able to control her feet. And you guys have probably heard us or seen people use the toe yoga exercise, right? Just seeing how you can control different digits of your feet. And she couldn't really do it on that side, on the left side. Right wasn't fantastic, but she couldn't do it on her left at all. So it's not necessarily like a functional item, just keeping that in mind, I guess. So that first visit, we stayed working on her foot.
I'm just looking at the focal point.
Oh, okay.
Yeah, go for
I
it.
thought you were just trying to get closer.
Myopia.
So the first visit, we focused primarily on her feet because that seemed to be the bigger thing standing out to me at that time. I worked through some of the toe yoga assisted, would have her hold, some of her toes down and try to move the others. Then used like a spiky ball, lacrosse ball to roll her foot to get more proprioception into her foot, and then also a short foot drill, trying to get her to activate the intrinsic muscles in her feet. Sent all of those home with her that day. And then in the second visit, at the time, I guess I wasn't fully sold on it being the tendon yet. And so I used some dermal traction over saphenous nerve, infrapatellar branch, that region, with a side lunge to see if that was going to change any of the pain audits. It didn't. And then we did isometrics on her left knee as well, in a just knee extended position sitting on the table, and then also in a Spanish squat, both of which were not necessarily helpful at the time. And she would kind of get an increase in the pain when she came off of the ISO, stepping out of it, which in the office we were talking a little bit about how to differentiate it between the tendon, muscle, anywhere in the body, and correct me if I'm wrong. When you come off of the exercise like that, or you come off a contraction, if that's when the pain occurs, that's more often going to be tendon than muscle belly. Whereas during the contraction would be more of the muscle belly. So didn't change what she was doing at home. The foot control was improving the second visit, so I just had her keep doing that. Third visit, we start working centrally, working on her breathing, creating intra-abdominal pressure in a supine position. And then I also carried that over into hang stance to try to get her foot connected to that as well. Again, then I sent her home with breathing. So she's still doing the foot stuff at home, and then...
I always try to send people home with breathing just so they don't die.
Yeah.
Just in case.
That is a good one.
Yeah. I would agree.
Real quick, bonus question. How old do you think Thessaly's test is?
How old?
When was it first recognized as a viable orthopedic test?
27 years.
Nope. It's 67.
27, 67. Years ago is what you're saying. That's
Yes,
how old it
yes.
is.
I'm going to go with 18.
Do the math. It was
I'm gonna go with
2005.
Whoa!
This guy's been reading his
It's because I graduate next week.
Yeah.
I'm still gonna be called
Give it
a
up
clerk.
for the clerk.
I'll still be called a clerk around here, but it's more so a clockter now.
Yeah.
A clockter.
Okay. All right.
Barely know her.
Or a clerkter.
Okay, so we're back. Visit 4. Visit 4, we're progressing some of the breathing, trying to get into a dead bug position, which I don't think I sent her home with the dead bug that day because she had a hard time controlling her lumbar spine as she started to lower her leg, want to come off the table. So we basically just worked on holding that unsupported for the most part that day. At that point, I also sent her home with the Spanish squat as an ISO for the tendon itself, because after we talked that day, that kind of further solidified for me that it was the tendon and not something else. And while I wanted to work on the function at the same time, like she wants to get back to, this is the beginning of the indoor season. The first meet is this weekend, and she's not going to be running this weekend, but she wants to be able to get back as soon as she can. And part of that's going to be getting the tendon ready for that. So send her home with those isometrics. And then do we want to talk about the conversation we had about return to play before? Because we had that, and then I've seen her twice since then.
Sure.
Yeah.
Okay. So I had brought the case to the other... What?
Well, let's talk about this for a second,
I just
though.
said it was your case.
Why do you think there has to be a delineation between working on the tendon and working on function? At least that's what it sounded like. So, is that you had to pick one or prioritize one?
Yeah, I guess because there's truly an injury to that tendon, and I would think that the best way to go about repairing it is to load it. And while she needs good central stability and the ability to control her feet to help offload that, she would also, like, we could speed it up by helping the tendon repair.
What's wrong with the tendon?
I'm assuming that it's micro damage. Just
Where underneath the umbrella?
oh,
Does it
okay.
fall?
Yeah, so it wouldn't be an itis because it's not. Well, she says that it's swollen sometimes after practice. I've never seen it swollen in the office. I'm not doubting her, but and then reactive versus degenerative. Degenerative, like, I mean, this has happened before. It's been a couple times this has happened. So I guess that would lean more towards the degenerative, but I don't know. She's also like 16, so.
Probably reactive. But then I would also, like, to play devil's advocate, what if how she loads her knee due to, like, how her foot works or whatever is just going to keep damaging the tendon?
Right. Which is why I guess I was trying to do both.
Which is why I think we are always doing both. Which we kind of talked about, that it's not like, yeah, you might have to lean heavier on one than the other, but if you send somebody home with a Spanish squat and they don't know how to connect their foot to the ground, then they're already altering the force to their tendon more than likely. They're not maximizing it.
Yeah.
And then if they try to recreate that force generation in, what's the sport?
Soccer and she's an 800 runner, 400, 800.
So when the first thing is, as Greg Cook would say, is protect, I think that comes into it. It's not just rest, brace. It's also like protect them from themselves or whatever got them there, so.
That's also, so she is resting right now. I tried to like allow her to keep doing some stuff for the first 2 or 3 visits. And I think visit 4 was when she had started track practice, or, she had 3 or 4 track practices before that visit. And each day it got worse. Each day it was like, now it hurts in the morning. Now it hurts before I start running. So she's resting from running, still doing that though. And we had all talked about what like return to play looks like for her. Because with an injury, like she would need to be able to do certain things to be able to, for me to say that she could run safely, other than just doesn't have pain when on our painful audits. And that was, not having pain with a squat, and a single leg squat, like a pogo jump if she's going to be running, and then something like a rebound off of a box or just landing from a tall box, because those are things that she also does in the weight room when they're lifting too. So then visits 5 and 6 were this week, and visit 5 we started incorporating kind of what you were talking about just a second ago, her foot and centrally loading the tendon all at the same time. So I put her in like a single leg RDL, and then also like a hip airplane in that RDL position. So teaching her how to keep, she had very little engagement in her foot while she was in that position at first. I could just move her toes all around. And so I cued her to press my fingers down into the ground with her big toe as she moved around her hip, letting her use the squat rack for support. And then sent her home with that. She's still doing the Spanish squat that day. Then
why an RDL?
It put her in minimal knee flexion. There was still some. And she could still like load everything isometrically, I guess. That was my thought process.
Do you think you're getting enough load on the tendon?
Probably not as much as the Spanish squat. Because she's getting into more flexion with the Spanish squat. She's not going down to, she's probably
Parallel.
a quarter squat. Oh, she's probably not even that far. Yeah.
Because of pain or?
Yeah, it gets her like close to parallel. So I just had her back off of that and went right there. Then later this week she came back, doesn't have pain on palpation anymore, and Thessaly's wasn't bothering her either. So then we took the Spanish squat out and turned that into kind of like an eccentric single leg squat on a wedge. I just tried those out in here first, and she was fine with those. So she was getting more knee flexion. And so I sent her home with that as the replacement for the Spanish squat. And then we also did like a clock drill in here, just holding more knee flexion while she moves around at the same time. And then honestly, part of that was just us playing around because I had her do that while we were throwing a ball back and forth, doing all this stuff, but didn't necessarily send her home with that. So she's not running this week. We'll see how she's doing early next week. Because she also hadn't really been doing much in the weight room. And I told her, I was like, you can do deadlift type things that look like a hinge because you're not getting in as much knee flexion. I probably wouldn't be doing squats yet, or jumping up to a box or something like that. But that's where we're headed next, I guess, before I say go run.
And what's her phenotype? I would assume being a young
she's
female.
She's pretty flexible. Other than like a little T-spine extension, that's about it.
And how long was it going on before she started seeing you?
This time, maybe a couple weeks.
And you've seen her 6 times?
Yeah, I think it's been, 3 weeks.
Yeah. So when are you going to start doing like ballistic faster? Because if she's stretchy, right, you want to kind of like stiffen stuff up would be the typical mindset.
Yeah. Soon.
So in a scenario, this is kind of, what do we call it, enthesis or enthesopathy, insertional stuff. You're talking about maybe there's compression or maybe there's not, maybe it's tendonitis, maybe it's reactive. One of the big things is, I would say, taking the phenotype of the person and trying to do what's going to behoove them way on the back end first is almost a diagnostic test. So like we were talking for her, for soccer, she's going to need to be able to jump on those boxes and probably do a rebound, do a side-to-side rebound, and then cool, there's no pain. But that could be some of the stuff you do very first to see does it improve or get really bad if you're just doing a repetitive, with Achilles stuff. If you had a mid-thickness reactive tendinosis, like there's no reason that you can't start doing that day one. We think there's this like stepwise fashion through not necessarily, right? Because it's, again, you're trying to get the tendon to accommodate to handling forces that they're not doing very well at. You'd say, well, that could be very irritating to a tendon, maybe not. So I would say for return to play criteria, you play around with that kind of thing that you'd be looking at both for what they're going to do long term to build the tendon one way or the other, but then also what they need on field. And again, if you can overlap those, I think it's even better.
So almost just start there and work backwards to see where.
Yeah, but if
where
they
would be.
blows them up, then you're like, okay, pretty far off that.
Yeah.
But then that's also what she's going to be doing in soccer. So then it's that's the return to play.
Yeah. Yeah, you joked about the Achilles earlier, but that's my bias in that is whenever I was dealing with it in school, I had two. It didn't start until I was in chiropractic school, but whenever that popped up and I was working with my student clinician, we did that slow build back up to being, isometric, eccentric, ballistic. And so that's how I approached it. And then COVID hit, and so I did the same thing for a while. But
that's the whole reason that I like knowing where you're at on what it is, like Daniel was saying, how long's it been going on for him in this episode, their phenotype. You put those three things together. I mean, let's just her scenario, insertional, really flexible person. It's happened before, right? And it's kind of an acute flare up of this scenario. I think you would want to load the snot out of that thing ASAP. Right, you're not saying it's red hot, swollen. Does it show like risk of like, oh, she could rupture patellar tendon? She's pretty young, pretty resilient. She probably needs to stiffen up in general. Her feet don't work awesome, so it's like jump rope might be one of the first things to send her home with, because you're having her do RDLs, which is minimal knee flexion. Now she can do like basically repetitive minimal knee flexion with her foot activated. Seth and I were talking about that with my runner guy today, like how trying to like overlap a bunch of stuff to get back to like the main thing we want to work on, so just, and then we talked about that a lot with your case of like, well, what's the goal? What would you want to be working on? What are we doing in the end? Not just like, what is it? Patellar tendinopathy. Well, what's the expectation? What do they need to be able to do? That's what you always got to ask yourself. Yeah.
Anything else?
Anything from you?
I mean, if anything, if they're not so acute day one, if they're jumping up and doing that, it's like, why not watch them day one? Because then it's just like, if you're working on the how-to, it's like, they may not be able to move their toes, but then what if they did the drill and did it awesome? It's like, then you're now doing something that you didn't have to do if you had just watched them the first day. I mean, of course, if they're super acute, then you can't do that.
But I just think the ghost of like the Christmas past, present, future, like Craig Levinson's all three of those, and you just over your shoulder all the time, just being like, dysfunction doesn't exist. Stop putting yourself at the center. And then he's gonna put up some meme style off Instagram.
And the only thing I was gonna add to it, I
slideshow.
don't think you may have mentioned it in the SFMA, but it's like, if I'm ever seeing anybody like bilateral rotation, single leg balance, and it's like, to me, and it doesn't matter the sport, it's like that's what I'm trying to figure out the fastest.
That was another thing that I didn't mention. So after the fourth visit, we went back and checked the SFMA, and left rotation and single leg stance bilaterally were all functional.
Nice.
Multi-segmental extension was the only one that wasn't.
And what I always say with that, when you didn't check it after treatment, you have no clue if they went home and slept different, and that's why they move like that. I mean, that's just God's honest truth. We also don't know if what we did in the office was the full effect of like, oh my God, you rotate better. It could have been how we talked to them. It's 30 minutes later getting out of the car. So I'm always trying to like put a check system back on me, like, don't be like an idiot. Don't think it's like what I did. But like Seth worked with a patient I've seen for a long time, hip complaint, adductor, extensions, 3 different top tier, rotation, what all changed?
Flexion,
rotation,
and right rotation.
Yeah, all changed just doing that. It's like, that's a pretty good indicator that little move is kind of needed.
Yeah.
But had none of those changed, or only one changes, I don't know, we'd probably still send them home with that in that scenario, just based on presentation, what we typically do. But you know what I mean? Like, try to always like beat back the bias of like, oh yeah, that's better. Cool, that might be the case, but like, what if it's just a good day? Still gonna have like really, really objective. That's why I'm not a big fan of that as like our check. It's for them.
Yeah.
But when you see also somebody show up repeatedly with the same thing, which we also talked about, it's always the same thing.
Yeah.
Then you're like, God, am I missing something? Or is this structural? Or are they trying to blockade an injury? Whatever it is. Yeah. Cool.
Your turn, Laverne.
Big
turn.
right turn with this case. Yeah.
My turn, Laverne. All right. I forgot how old he was.
Older than a Thessaly's test.
He is older than a Thessaly's, that's for sure. All right, so I had a 37-year-old male. Got referred to us by an ortho that we're really close with, like right down the road. I got his chart, or I got the file that has everything in it, and I looked at it, and it's 15 pages long. And so he filled out, I didn't get a chance to fully look at the whole paperwork because he filled out his paperwork like 10 minutes before the appointment. But went through, kind of like I said, just he on his paperwork said that he had some neck pain, back pain, radiates into his hands and his legs. So after talking to him, asked him about everything.
Did you immediately think he had multiple sclerosis?
I did not think he immediately.
Afterward?
Maybe if you see me, it's subpar care right now. Yes, because I didn't think MS.
As a clerk, never even registered. Guys were walking around with lesions in his brain.
For sure.
It's all good. No worries, Seth.
It's all good.
It's my malpractice.
That's why I didn't think of it.
Yeah.
I would say we've all been there before, but
You're the first clerk.
I am correct. Like I said, he presented with neck and back pain. He has numbness and tingling into both of his hands and hips.
All the time, or
all of the time.
Okay.
So like
MS.
constant. Yep, MS. Yeah. Asked him, if there's any time that he ever feels any relief, and there's not. Anything that he does to make it feel any better, nothing really helps it at all. No ibuprofen, no medications, no nothing like that.
You know why it's good? A lot of people don't listen to our show.
Why?
We probably get some MS association hate mail.
For sure.
You hating on us for our numbness? No.
and that's what they would say.
That's probably our next review.
We get a review.
It's probably our next review.
I loved your show until you hated on MS people. We're not hating on you. It's overdiagnosed, misunderstood.
Yeah.
That's Alex in a nutshell.
Alex, how does it feel?
I don't know. I feel like I've had less chirps thus far in this podcast. I think we're doing okay.
Well, we're just gearing up for tomorrow.
There we go.
Yeah, there we go. So we have the farm Christmas party tomorrow at 10 a.m. No, it's at 6:30 at night.
10 a.m. Santa's coming to town.
Dude, Santa does come down, and he's checking the list twice.
Oh, we should have got a Santa.
Oh, well. All right. So, back to
Still
it.
time.
MS.
Yeah, so the guy has MS. This complaint started back in 2019. He said he started having, more so his neck and his low back both kind of started around the exact same time in 2019. Can't really pinpoint exactly what caused it necessarily. He just remembers one day he was playing around with his kids and just noticed that his neck and his back hurt. And ever since then, he's kind of just started having numbness and tingling that's progressively gotten worse. Outside of that, that's pretty much all that came up in the history on day one. So ran through exam. He was dysfunctional and painful.
How dare you label that man?
I'll label him. Cervical spine flexion, both rotations, right upper extremity pattern 1, multisegmental extension, left rotation, right rotation, and single leg stance bilaterally. He's
We're all dysfunctional.
Dysfunctional and painful.
Oh.
But he can touch his toes?
He could touch his toes with no pain, and it was functional, but he couldn't extend back, rotate either direction, because I say it's dysfunctional due to the pain. He couldn't finish the movement because it hurt.
And where was pain? In his back?
Low back was for everything on flexion and down, so multisegmental flexion and down. That was all low back and into his hips, and he felt all the way down to his feet. Anything that I did with his neck, he felt everything radiate out into his hands.
So you're immediately thinking meningitis.
For sure.
Bacterial.
Yep. He had no fever, which I did check because that was actually something I actually thought about. But he had no fever.
Did you Soto Hall?
I did. I did some Soto Hall, and he was good.
Did you pop
Wait
his
on it,
pimple
guys.
his nose?
Huh? Did I what?
Pop his pimple on his nose. Did you
For
pause
sure.
it?
Did I cause his pimple on his nose?
That was a subluxation.
Oh, yeah.
Yeah.
Okay.
Come on. Once I adjusted that, it just, you watched it absorb into his face.
That nose just
The balloon.
All right. So I would say almost everything hurt. I say that some of these obviously were functional and non-painful, but most everything hurt. I didn't even check his deep squat.
missed a
Yeah,
lot
I
there.
missed it for sure.
Merry Christmas. I'm calling Greg Cook.
And then
We got a clerk. We got a real
and
clerk.
then just running through my
Real clerk move, Seth.
And then just running through my exam, I noted obviously that he had both rotation were dysfunctional and single leg stance on both sides. So I did inline lunge, just checking hips. Dysfunctional, non-painful on left and right. So he was painful standing. It was non-painful, but he couldn't do it on either side, on left and right. Went through cervical spine testing. Max foraminal compression was painful. Shoulder depression was painful. Passive range of motion of his neck was painful. All of these are causing radiating symptoms out into his hands. Like anytime I moved his head around.
We need specific orthopedic tests, or this is not legitimate.
Okay. Max foraminal compression and shoulder depression. Those are literally both cervical orthopedic tests that I checked.
Perfect. I feel much better.
Thank you.
Gray just texted me back. He said, "What the heck?"
Heck, I mean heck.
Heck, I mean heck. That's a DOQ special. I did Jackson's as well, just for, I know it's not a ortho on here that we have, but laterally flex his head, push down if anyone is confused. Beau Beard.
I'm never confused, just trying to clear up.
Yeah,
no
hey, that is,
confusion for the listeners.
that was painful again, both sides. So we kind of got that one nailed down. And then I went through lumbar orthopedics as well.
Did you do a decompression test?
I didn't do decompression.
Did you do any jaw tests?
Jaw test? No. I
Joel
didn't.
modification?
No.
No.
Okay, because we haven't quite gotten there yet. I don't even know what a Joel modification is. If any of you
First
listeners out there that went to Logan around the time of me and Alex,
It's on there.
It's on our
It
orthopedic test.
I
been
know.
explained to me before, and I don't remember.
Yeah, that's what I'm saying. It's on our orthos. But if anyone out there knows what it is, please let me know.
Yeah. Let me explain it real quick.
It has a
Just
synonym, right? There's another word.
there's another word for a multi-word Joel modification
Jaw
test.
modification, isn't there another name?
You slightly open the jaw and then push basically the mandible as far back as you can into the
Central
TMJ.
provocation relocation test.
Relation test.
Yeah, I guess. I wouldn't call that a synonym.
Okay, sorry.
Right?
You just
Synonym's
said
a
so many
word.
words.
You're cut off.
I do agree. That is, yeah. Okay, go for it.
Right. Let's see.
You're gonna
Lumbar.
kick us out of the restaurants.
Yeah, that's not gonna be good.
Okay, on a realistic note, at this point, what do you think's going on?
Yeah, when he's told you all this, everything's painful. Are you like a little poo-poo in your pants, or you got an idea what's going on?
I think it's got some central sensitization going on for sure. I haven't quite I wasn't nervous.
And when we're saying pain, 0 to 10, what's he experiencing as you're doing this stuff? Like, like when you do it, or just like, oh, that hurts?
Some were like that. Others were
Okay.
kind of like, eh.
Okay.
And I retested each one a couple of times, so I ran through all of them twice, just because when I did Jackson's on right side, lit him up, but then I did Max foraminal on the same side, and he was kind of yeah, that kind of hurts. So I just redid both of them,
Malinger sandwich.
just to make sure that I was getting the same thing,
Yeah.
and they actually flip-flopped the next time I went through. So Jackson's was kind of it's not that bad. And then Max foraminal, he almost couldn't get his head back there because it hurt. And then lumbar orthopedics, he actually had none that were positive. None of them caused him any pain. Even though he had all the pain up here.
But no flexion. Like he could touch his toes.
He could touch his toes.
Yeah.
So he has he had no slump, no Valsalva. He has nothing with straight leg raise, nothing with active straight leg raise. Nothing with Kemp's and Stork, nothing. Even though it was painful on multi-segmental extension.
Guy's a real liar.
So yeah, that's everything that I had for pain. So functional audits, went through palpation. CT is restricted. Thoracic is restricted as well. Cervical erector trigger point, breathing, and pec minor trigger point, because he also just brought up his shoulder's been hurting as well while we were just randomly going through the exam. And then, functional audit, CT extension, and thoracic extension are kind of my main two right there. Just because lumbar moved fine. even though he has pain down there, and I know it's limited and painful when he does extension, but he was on palpation, it felt fine.
Yeah.
So CT and thoracic to me were the bigger pieces, so I went after that with, I did CT, retractions first day, went back and rechecked all orthos, and all of them were cleared up, had him do 10 more, went back and rechecked the orthos again. Some of them were fine, some of them weren't. So I was kind of like, all right, let's go after maybe like something with like this T-spine. So I was like, I just need you to kind of knock these out at home. So we did first position and 3-month supine, just like breathing, in office day 1. Because in my opinion, we were talking about like central sensitization. I was like, if he's just like super ramped up, I'm just going to go after the breathing to see if I can't get something just to calm down just a little bit.
Does he seem to you in your first impression as an anxious, uptight kind of person?
No, he actually, like I said, he seemed pretty normal. I know we had it was an interesting phone call. Like, I guess like when we first asked for like some paperwork stuff, but day 1 he seemed super nice. Didn't seem like anything was just like out of the ordinary.
For people listening, he just basically didn't want to do the paperwork.
Yeah, he just thought that the paperwork that got sent over from the other doctor's office thought it sufficed, but it didn't tell me what was going on. It just told me their diagnosis and a bunch of other stuff. That was, I sent him home with first position and retractions. My goal was just to get his CT moving a little bit more and then just start activating like his T-spine a little bit. That was day 1.
And then right after that visit, Seth came in, gave me the clerk download, right? Like literally walked in, you're like, well, that was a little weird or whatever. And basically from what I remember, correct me if I'm wrong, is you're just like, stuff didn't match. You're like, I did this, stuff was painful, we did retractions better, and then all of a sudden I did another side that wasn't better.
Yeah.
Like, what are you thinking? And then how did we come about in the
so
paperwork?
I asked you, because I sat down, like I had like a break, and I was like, I need to look through all of like his paperwork again. So I got the the paperwork
Referral.
from the other doctor, and so it has on there like what they've diagnosed him with, and he's got cervical disc disorder, thyroid function test abnormal, ADHD, bilateral hearing loss, chronic pain syndrome, anxiety, epilepsy, history of viral illness, and male hypogonadism.
This is his primary care.
This is primary.
What if that was a PT?
Because he was on, it wasn't like you looked at his medication list or something.
Like I said, I glanced at it before day 1, but I didn't get a chance to like fully look because, like I said, he did the paperwork like in the parking lot before he came in.
Which is why, for anybody listening, we try to get everybody to do what they're supposed to, but leniency of just trying to get new patients in the door, they're supposed to have it in 24 hours before they get canceled or moved. It's just, we try not to like be extremely strict with that, but for reasons like this, which this would have been a scenario where,
So I mean, he's got something. He has 9 diagnoses right there that came through, and then next page, he has all of his medications. He's on, I think, what would you say, roughly 12 to 15 right there?
And those are all active? Because some of those diagnoses from primary care may be like post-active. Like that's just his history.
So all of them, it says like completed 9/11.
Yeah.
So
some of those are, that's just his overall chart.
Yeah, he had 11 that stopped on that day. And then he has...
Which would have been about 2 months before Seth saw him.
Yep. And then he has 4 that he completed about 2 months later. And then he's on 1, which is Clomid, which he just takes kind of daily. For like, it's like his estrogen blocker. Because he also says he has like low testosterone, which we'll get to here in this second. Him and Alex go hand in hand.
The data is not in, my man.
It's coming though. That's little. Let's take a commercial break. Upcoming week in review is going to be a breakdown of these 2 foos, which will be.
I'm Foo 1.
Be a doctor by that time.
And uninsured. Oh no, you're insured.
I'm insured. Don't you worry. Somehow that.
There's 26 on the same.
Let me just call him out. He doesn't have health care, so someone has to push him down the stairs. He's not going to make it.
If you see me outside on my bike, swerve into me.
But no, we, to help them kind of learn how to read blood work panels and genetic panels, we got that for both of them. But then the joke in the office, for whatever reason it started, is that Alex has low testosterone.
Because I can't sleep.
Yeah, for a variety of reasons. So then we'll find out and then be able to do all that. But we're going to break down their genetic tests, their blood work results on episode, and just kind of basically what we do with a functional medicine patient here. Yeah, that'll be upcoming. Back at it.
Awesome.
Sponsored by Rupa. See ya.
Meds.
Anyway, so like I said, I started talking to Beau about some of this because he came over and looked at all of the chart, and he mentioned that
We haven't mentioned why we talked about it. That's in that paperwork, right?
Yeah.
What?
The account at the PT. Wasn't that in the paperwork?
Oh yeah,
That's
that
why
was
I brought
something
it
I
up.
forgot to mention that on the first
like the whole-
visit.
Well, that's a good transition.
Yeah.
Yeah.
That's pretty much where it starts.
Yeah, I guess so. It was on purpose. I left it out. So on the first visit as well, he mentions to me that he had a fusion at C4, C5 back in 2019 when his neck started hurting, which he had done by an ortho around here. Said that he went to PT and rehab a couple of different times.
Why did he have the fusion?
They just said he had fusion because he had like some degeneration in his neck at C4, C5. That's the whole reason why.
Okay.
I'll get to that other part here in a second.
I didn't really have fusion.
Yep. So went to PT twice. His first time, he goes, I didn't complete all of it. So he goes, I kind of left off and decided I needed to go back and probably like figure out what was going on with my neck. So earlier this year, he went to try again. And on during PT, I guess said there was a visit like 10 or something like that. And he randomly was just getting some like abdominal work done by one of the therapists. And he just like blacked out. Like there was, at that time on day one, he said there was no rhyme or reason to why it happened. He just remembers that they pushed on his stomach and he just blacked out. He said, I asked him like how long he was out, and he said he woke up about 10 minutes later in a different room and there was nobody around. So he said that he got, like nervous because one, he passed out without knowing. Two, he wakes up alone in a different room than when he like first passed out.
Sounds like college to me.
And then he mentions that he saw the therapist, I guess, that was working with him just like passed by the door, looked at him and said, you need to help me. And then the next thing he remembers is he's being like taken out by police because he like went belligerent.
Really sounds like
apparently.
college now.
Yeah. He like really went like apparently like belligerent, and he had to have the cops called on him. So he got kicked out of that PT place and he's no longer allowed to go back. So I found, so that's what I found out kind of towards the end of day one's visit. He told me all of that. Yeah.
Flag for me when Seth started talking about it.
Yeah.
That's right.
So then we looked at his paperwork. He's has been on like 15 or so different medications. And he also brought up that 5 of these have something like psychological type like drugs that he was on, whether it be
antidepressant.
Yeah. Anything,
Anxiolytic.
depression.
Yeah.
He was on like ADHD medication, all of that. So he brought up, and he's like, if you start seeing, like, I guess around 5 or so, or at least that many different drugs that they're on, you need to start thinking of past traumas, like whether they be in childhood or not.
It was more so the story in the PT. So the most vulnerable portion emotionally on a human body is your abdomen. I mean, that's both, woo-woo, but, legitimate from an ectodermal standpoint. So when you see somebody, if he legit just passes out from touching, I mean, that's it could be a very deep-seated repression of trauma. Like you're literally just trying to shut down as you get into a vulnerable zone. Then you back it up with this guy's on a multitude of medications for, anxiety, depression, whatever it be. and then has multi-site pain that doesn't really change or fit the bill for an ortho test. And that's exactly what I said to Seth. I go, no, that makes sense. I go, I would just ask about past trauma, especially in his childhood. You got to ask, what other sexual, physical abuse, whatever it is. I go, it's not a fun conversation, but it's what I do.
Yep.
And luckily, that was only one visit in.
Yeah,
Not like you're 4 visits in. Like, okay.
But the other thing is all of those drugs as well. He had them, I guess, filled twice, and on the second time, it always was like doubled.
Yeah,
So like they upped his dosage like by almost double.
And that was via his primary care. Do you know?
I have no clue.
Psychiatrist or
Well, he wasn't seeing a psychiatrist at this point.
Which I just think it's dangerous when a primary care just starts pulling knobs and levers like that with multiple medications, but that's how it goes.
So yeah, he has no psychiatrist up to the point that I know of right now, at least through visit 1. So visit 2, I see him 3 days later. And so I started off the visit, just asking how everything had been with, the exercises that we did, how his week had gone, yada, yada. So I was like, all right, I looked through your paperwork again, saw that you had, all the different drugs that I talked about with Beau for, like ADHD, depressants, things like that. I was like, so I just need to ask, is there anything from your past, like in, childhood trauma, anything that maybe you feel is significant that has happened, early in life or whatnot. And at this point, like, he just breaks down like in tears. We're talking he's probably about, I don't know, 6'1". He's about 230. Like, he's a pretty stout dude. So it's
nothing like Paul Bunyan that Alex saw today that got crushed by an
330.
80,000-pound railroad car. He was like,
Pushing off of him.
and okay.
80,000, yeah, at an 80,000-pound car, yeah.
No cuts.
No cuts, just torn labrum.
That's that tough skin.
But yeah, so he just like breaks down like in tears, like to where he almost can't like talk. So shut the door, and he told me that back in 2009, his mom got diagnosed with liver cancer, like stage 4 liver cancer. It had spread, I guess, to a couple of different other organs as well. So they said that she had a very short time to live. So he told me that he basically, I guess, suppressed all of his emotion with that. And how do I say it?
He just didn't want to deal with it.
Yeah, he didn't want to deal with it. He like already dealt with like the mourning of his mom before she actually like passed. So that
just like partitioned it. And
Yeah.
was like,
so she basically got diagnosed, and I think he said that she had passed away within like 3 months of that happening. So he basically said that since then he's been trying to, I guess, kind of run away from that, not really deal with it all that much. He said, I've been on drugs, alcohol, all the medications as well, trying to kind of suppress all of dealing
were
with
you
it.
like real quickly like you tried Legos? Like,
I did not ask him about Legos.
Didn't know.
It didn't quite come up at this point.
Oh,
It will
yeah.
come up.
Sometimes
but
you got to cut the thick air.
But yeah, that's basically everything he told me. He goes, for the past like 15 years, I've been trying to basically run away from it. And he goes, I've noticed that it's starting to kind of come up with, things in like my marriage with my kids and yada yada. So he has a ton of, I guess, I don't say a ton, but he has a lot of like home life stuff that he doesn't necessarily attribute to like, any one thing. It's just he remembers like with his mom, like ever since then he's been trying to suppress it. Ever since he kind of got off, I think he said he's been sober for like 2 or 3 years, at least off of alcohol for about 3 years. He still does like marijuana. Trying to think if there's anything else that he like does, but he said that he's basically off of all medications because they made him like super fidgety. He started having like insomnia, restless legs. He started having like some suicidal thoughts or some things. So he goes, I had to come off all of that. Mm-hmm. So yeah, that's basically where we're at. He also said that after that time that he got kicked out of PT, that he got assigned a social worker that he is like, I guess, his quote unquote therapist that he sees, and he also meets with his pastor that's at his church. He meets with the pastor every week, and then he meets with his therapist bi-weekly. Yeah.
But luckily, we have Dan Marvin, who's nurse practitioner. If you haven't listened to Dan's podcast on the Dr. Beau Show, I'd go listen to that. Because Dan is not unsimilar to this guy in presentation. Dan, 7, maybe 8 years ago, was at that time full-time emergency room, pediatric nurse practitioner, going balls to the wall, basically, like working full-time, working out 2 or 3 times a day, as he says now, probably to suppress or like burn off stress of dealing with kids that are, dying or dealing with major trauma. And never really had an injury per se, just like this guy, but started having low back pain, and then started having neck pain, and we were heavily involved with Iron Tribe, and then we're rehabbing him, and I think him being in the medical field, being surrounded by people that can go grab imaging, all of a sudden he shows up and he's had a lumbar fusion, and then it like precipitated into they want to do a cervical fusion. And so Dan went through this whole journey. You can go listen to the podcast, going to Mayo Clinic and going down the chronic pain path and reading into John Sarno's work and studying at Michigan University. And so now he is our basically chronic pain coach or consultant, whatever you want to call him. So luckily we have him in our back pocket, which this is like this guy. And this is also something I said to Seth that I think is worth noting, that, because that guy was that second visit when you guys addressed it, that you kind of said, hey, I think you need to see Dan. Mm-hmm. And until then, like, we need to kind of like chill out. And he goes, well, I still want to see you because you're the only person that's addressed this, or, something like that, which you built trust and rapport just basically off of noticing something.
And I did see him one more time after that.
Yeah. But my take on that was, from what we know, that could be the most damaging thing to him, is that he's now built a bond with you. If he has success with Dan, or just stuff starts to change, he's going to tag you to that. It's just like a neuro tag from pain and movement. And that's like very damaging. That's a bad relationship, right? Even though it's good for him, it's bad. It's just like him being our barbiturate. He gets relief and he tags it to that. Mm-hmm. So I was like, you have to cut ties with him until he addresses that. Like, we know it's not musculoskeletal. He showed up like a malingerer. Some stuff's positive, some stuff's negative. It's like, it's no different than what Seth said with his low back. Stuff hurt, but it felt fine. So I worked on his T-spine and CT junction, the exact same thing. His bigger presentation was psycho-emotional. Luckily, we were aware enough to address it. Luckily, we have somebody here that literally that's their specialty. Mm-hmm. And, Dan, post first visit with him, and she's only had 1 visit, right? 2 visits with Dan, was like, he is the perfect candidate. He's seeing a therapist, so that side is kind of taken care of, which is not Dan's thing. Dan is there to kind of show people maybe things they haven't seen, not dive so much into the psycho side or the emotional side, but then say, hey, there's tactics to deal with pain from the psycho-emotional standpoint. You still have to address the psycho-emotional, or it'll never go away. But you can't handle those symptoms with musculoskeletal care. We know in chronic pain land, stuff gets worse over time, mm-hmm. right? Like, you go away, he can't find somebody that's Seth, and now his symptoms ramp up. He's back on alcohol and whatever.
He put a tie, or I guess he said, I was the first one that's addressed it this quickly, because he noted that the day that he passed out in PT was the day that his therapist there asked if there was anything from his past. And he said, as I was telling him the story about my mom, that's when I passed out. Yeah. He also said that he started, I guess, putting some pieces of the puzzle together a little bit, which is, again, why Dan is really good that we had him right there that he could refer to, and was able to see him within the next week almost. Was he said that he remembers first feeling his neck back in 2016 when his son was first born. He had to get taken, his son had to get taken to the NICU, and right as he got told that he had to go there, he goes, I remember my chest and my neck on the right side just like started burning and hurt since then. And he goes, I remember that it happened once I thought about my mom because I wanted to call her to just let her know that her, grandson was like here, but I couldn't share that with her anymore because she's not here anymore. And 2, I had no clue what to do. I just wanted to call her and be like, what are the steps I need to take with like my son dealing with this? Because she had me. So like clearly like she has some at least idea. And he goes, at that moment I felt alone in this world, even though my wife is right there and all the nurses are around. He goes, I felt alone. And he's like, that's when my neck started hurting. Yeah. And it kind of sat with him, got an image done because he couldn't figure out why his neck hurt. Got the surgery done, which is the worst thing that could have happened. And then it still persisted. He also mentioned to me after that second visit that like while we're like in the room, like he's talking to me, he goes, this is the first time since my mom's passing that I haven't had numbness and tingling like in my hands since this has like been going on. So
which the other thing we talked about is the 5-point questionnaire, which is called a Nyheim questionnaire for anxiety. 2 of the 5 points, one is numbness, tingling in your periphery, right? And then one is like shortness of breath, things that like, so to think the number one, this is a very good clinical point, cause of bilateral upper and lower numbness tingling is anxiety. It's not peripheral neuropathy. It's not MS, obviously. It is anxiety or breathing or, one or the other, physiologic, neurophysiologic, whatever you want to call it. So right there, you're like, well, this is like Alex asked, like maybe it's kind of an anxious guy, even though it didn't seem like it. And then we always talk about pain being a perception, not a realized thing from a, axonal standpoint. Like, well, that's what this is. So I think often we like, again, partition the biopsychosocial into these 3 things. No, it's like the thing, and he may just be more of a psycho-emotional pain response person in general with a little more anxiety. And literally he could smash his foot with a hammer and be like, But then his mom passing away is absolutely just like a raging fire of pain for him because that's how he like responds to things. So I think it's no different than him. He may have pain is a genetic preset for some people too. Alex may have a higher preset for pain, and he deals with more things as we would just be like, that's kind of tight. And his is like pain. And that's like a different response. I know from genetic data, I'm a low response on a lot of that stuff. So that, I think that helps understand the scenario that you're dealing with. So you're not just like, this guy needs to go to a therapist. Well, yeah, that's part of it, but it's not like you understand the whole human, and that's what we're always trying to do. And
also on that second visit, I drew out that matrix that you talk about with like CNS, PNS, musculoskeletal, and then like func med. I drew that out for him like while we're just sitting there talking because he came to us because he got referred here by the ortho, Dr. Davis, got referred here. And so Dr. Davis, told him like about like kind of what we were about. So he knew coming in that he's had a higher expectation, I guess, of like, how we treat around here. And I was like, you came here for a specific reason. So I was like, we're always looking for like the why behind everything. And I was like, that why may end up not being with us. That why could be somewhere else. And we're just like, we always try to be the best at triage, which is like getting someone where they need to go. And that's the best, why you could, like why you're in the room. So I was like, that might be like, with, like a actual like therapist. That's where I asked, I was like, do you see like a therapist? And that's when he brought up, like the social worker and his pastor. And then I drew out, like, I was like, yours is like mostly like, I was like 80% of this, in my opinion, is going to be like CNS. I was like, if you're talking like the first time that you haven't had any neck pain or tingling in like hands and stuff like that in, I guess, almost like 7 years is after you just told me about your mom. I was like, that almost seems like everything is out of my hands. I was like, there's some musculoskeletal components to it. I was like, you obviously don't move very well, but I was like, that might just be like that might loosen up because you might be able to let go of some, just like, I guess, subconscious tension of emotional trauma.
Well, even you talking about that though, I think the matrix needs rewritten because it's so, I can't remember the last book I was reading that was talking about this, that you can create the exact same physiologic response of standing on a cliff by thinking of standing on a cliff, right? So to think that like, well, when I think CNS, I think central sensitization, brain lesion, things like that, peripheral nerve sensitization, something like that, peripheral nerve entrapment. But then you can have an emotional response that gives you a physiologic presentation, which I think is very different than saying that central nervous system. I think that's a different system, right? It's not, your hypothalamus, creates that, or your limbic system creates that. Because we know that like humans have that unique trait to like think themselves into a physiologic state where you can literally create. I've dealt with patients that have had legitimate life-ending pathologies that seemed very odd in the realm of who they were surrounded with, that dealt with the exact same scenarios. And it's just, you always ask questions like, what the hell is going on there? So I think I need to rewrite that and be like, well, yeah, it's not just all physiology, right? There's an emotional component, like we said, psycho-emotional, which are both outside of the realm of, the brain, like the mind and the brain are different. But I think to put a bow on all that, and we've talked about this a lot in here, this is a pain, whatever you want to call it, pain science, psycho-emotional, the psychosocial side of the three-pronged biopsychosocial. But Alex and Seth could echo this, or I guess confirm that I think probably at the end of where Daniel got out of school to now has gotten overrun with the thought process of chronic pain being present with everybody. That pain is a representation outside of pathoanatomical pathology or dysfunction, biomechanical, whatever. It's always a part of it, but that's why we have this whole matrix system. But like, it is not, I think we've gotten like it flipped around and it's like, well, pain is this thing that's over here. And then like, yeah, we might pay attention to mechanics, but like, we're not going to diagnose anything because it's just pain. I think that's very dangerous. In this scenario, it was diagnosis by exclusion. Did a bunch of tests, nothing matched. Right? You keep going after stuff, dude, nothing matches. Happened to ask a question because all these drugs and this account, and then you're like, God, I don't have any tools to help. I shouldn't be helping you even if I do have tools to modify symptoms. You literally become like alcohol. Like you're just dulling things for this guy. So I think that's a big point. That's kind of a pet peeve of mine. This was around when I was in school, when you were in school. We've listened to Andy O'Connor talk. We've been around the horn, but it's just like, it's not, pain is perception. We get the whole paper cut thing versus, cutting your arm off. Just, I would say quit labeling everybody as just, oh, this is pain. And then we're going to treat it, it's like put them into categories like, no, do your job. Just like you would diagnose, like we say in here, like make sure it's not an injury before you start working on function. Well, yeah, put it into a category. If that's not the biggest category, well then leave that alone, because that might take care of itself. If somebody can't move well and they're depressed and you think, oh, it's the depression that's leading this chronic pain cycle, if they can get out and walk because their ankle moves shitty, cool. Like you did your musculoskeletal stuff that did help the psycho-emotional component, but you prioritize it correctly. And that's, we were talking about that today, like what do I want to teach on? That's the kind of stuff is like, well, how do you point people in the right direction? I just think it's whatever's hot. Oh, it's pain science. Oh, it's, DNS, it's ART. Well, those are all great, but it's not just one in itself.
Well, I was since I kind of got an understanding of what was going on, what I think he did perfectly was like huge, 18 papers where what's been going on. And then he does his own test and he's like, I don't know, yet 0 red flags. Yeah. So he thinks, okay, I can get this guy moving. And it's either going to clear up a ton of symptoms that is musculoskeletal, or it's like, now it's like I get him back in here, and then now I can dive a little bit deeper, and then that's where everything ended up coming out. And so I think Seth played it perfectly by not trying to figure it all out day one, and then yet letting it all play out because the red flags weren't there.
Yeah, keep it fundamental even though nothing's... Because that's what I was asking, like, what were you thinking when all this stuff's going down? And like Daniel asked, like, what's going through your head, so...
I guess it was kind of good. Like, I know he's a completely different case, but for those of you out there who are brand new and you have a bunch of hot, low backs that come in...
And Seth's had a bunch of complex cases.
Like
that's just the best thing for him, because that's not going to be...
He was one of 3 in 2 days that came in, I'd say, on complexity level like this. Not like psychological like this one was.
Yeah, but like
But yeah, it's. I guess I didn't get like super nervous because like nothing like red flaggy that came out in his history. Like no like recent weight loss. There was no weight gain. Like nothing like provoked it at all. Like he was sleeping fine, wasn't waking up. Like it. So it was like most of my big red flags I got, I guess, like checked out. Besides like he didn't deal with something from his past. And
Yeah. When I know we're hitting an hour, but to drive the point home, Seth's been with me on a lot of these visits with this guy. Guys came in that 2+ years ago fell on the ice here, which is rare. Falls on his hip, has immediate hip pain, and then that pain starts radiating down his leg. He comes in, we treat him for low back. His low back slowly, it wasn't super fast, gets better, but then as his back got better, I think I would have to look at the notes exactly. He had a hiatus in care, and he comes in, he goes, I've had foot stuff before. We're talking 5 years prior to the falling on the ice. He's like, the heel on the same side that I fell on that hip is really starting to bother me. And he's saying Achilles, heel, it's random, comes and goes. We knew day one what this guy was going on. Like you start taking him into a neurodynamic, whatever you call straight leg raise, as soon as he flexes his ankle, lights up his lateral heel, where there's only, as we've said to him, there is literally, obviously fascia, but bone, no tendons that are directly there. You're basically, if you're fat, if you extend that far, but then your lateral calcaneal nerve, I mean, that's all that's there. It's like this is neurologic and you load it like that. At first, there was a little bit of a low back hip component that went away. And then it continued down this process. I say all this to, he came in Tuesday of this week, no better, frustrated. We've tried all this stuff. He did over the counter, like inserts, like super feet. We did a little on foot, foot posting to see if that changed. It made it worse just from the pressure there versus the mechanical change. And he's like, what am I supposed to do? I was like, I would do orthotics to change how your foot's moving to offload that nerve, which then it goes into this whole, like, well, what does the nerve need to heal, all that. And I came back in, I was like, I just had to, because we were talking about Alex's case, like, I had to stick to my guns because I know exactly what's going on. So it's kind of the flip of Seth. Like, this guy had been doing all this stuff, so I was like, no, this stuff feels good. Like, with this guy, he's like, what am I doing? Do I need to get surgery? Do we get an injection? I was like, I know what it is. It's not getting better, but that doesn't mean, like, it changes what it is. Because he's like, what image, which brings me back to the main point that we'll wrap up on, is like, your assessment needs to just be ironclad. Because that guy, his whole family loves us. I mean, he sees, Daniel sees part of their family, you've seen part of their family, I've seen their family. If he's questioning me, and he was like, what is going on? What, and you don't know. I mean, they're going to like see right through that shit, and then they're going to go someplace else. And like, you've not only lost their faith, but like, are you any better than you were when that guy came in 2.5 years ago or whatever with his back? Like, you should be. But I was so confident. I was like, I had no qualms with him questioning me. It's like, I would too. Like, why isn't it getting better? I literally told him, like, I don't know. I know what's going on. We've done everything. It's just not changing. So this is the next thing I do. Same thing here. Like, it doesn't match what's going on. Like, and the only way you can trust your findings like that, whether you're a new clinician or you've been in practice for 20 years, is like, you have confidence in what you're doing because you're actually like using, I guess, valid techniques and assessment things. You're not just resting on like, oh, like, let me do the same thing I do all the time. Like, you're literally checking yourself all the time. Well, what does that mean? What did I find? That's the only reason I think all of us like get so hopped up on this, is like, we're really trying to find out like what's going on with this person. Not just like, we could get everybody feeling better. Yeah. Super easy. That is way different than like changing things long term. Anything else?
That's a good wrapping point.
Yeah. Hard hits. So look forward to going through the mutants blood work next time.
We're getting stuck next Tuesday.
I'm going through the new great reviews.
Yes, there'll be at least 40.
At least.
We'll tell you how the farm Christmas party went down, but the next one will be after the New Year, right?
Yeah.
Yeah. So probably the first week after January.
Unless we did it the 18th.
Aren't you
Right
out?
now. Yeah.
Sorry, not the 18th.
Yeah.
22nd.
In January. So we'll see you after the New Year. Bye.
Good New Year.